Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Providing the Palliative Approach to Care for Patients with Hematological Malignancies. This training is geared toward the healthcare professionals in our community. Today, Jocelyn Brown will talk about how you can support patients and families in the palliative care stage. Let me introduce myself. My name is Leslie Ann Guiney, and I am the Community Services Lead for Eastern Canada, as well as the Grief, Loss, and Palliative Lead. Before we begin our main presentation, I would like to share with you our mission and highlight some of our resources that might be helpful for you and your patients. At the LLSC, our mission is to cure blood cancers and to improve the quality of life for those touched by a blood cancer and their family. Ultimately, we are here to serve the community. We offer guidance and support to people affected by a blood cancer every step of the way. We offer a continuing education program that you can join free of charge. Last year, we sent a survey to hematology oncology healthcare professionals around the country. A need for training on blood cancers has been clearly identified. You can register to one or more of the trainings that you can do at your own pace and receive an electronic proof of participation. We offer a variety of educational resources and services to those affected by blood cancers, as well as for healthcare professionals in our community. In addition to disease information booklets, fact sheets, and videos, we also offer valuable services such as a peer support program, virtual support groups, a multitude of webcasts and podcasts, a COVID-19 resource center, and access to our community services leads in every region. We invite you and those affected by blood cancers to visit bloodcancers.ca for more information. All of our materials can be downloaded or ordered through our website. The process is very simple. With this handy electronic form, you can order materials to be shared at your location. It just takes a few clicks. If you have any questions, please reach out to the Community Services Lead in your region. We're always happy to help. Emotional and practical supports is important for the LLSC. Our peer support program has been identified as a key service, but many do not know about it. Volunteer survivors who are at least 1 year out of treatment, selected and trained, share their stories with newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are considered to ensure the best possible match. This program helps to build hope and alleviate anxiety, as well as create realistic expectations. We also have virtual support groups offered from coast to coast. They are professionally facilitated. Our group support give the opportunity to the blood cancer community to connect with others who are facing the same challenges in the comfort of their own home. Each participant builds connection through group discussion, sharing coping methods and information and breaks isolation. Visit our website, www.bloodcancers.ca, for more details. It is now time to introduce you to our speaker, Jocelyn Brown. Jocelyn completed her master's and undergraduate studies in nursing at the University of Toronto. She has worked as a pain and palliative care clinical nurse specialist at Princess Margaret Cancer Centre for the past 13 years. This role includes collaborating with the interdisciplinary team on acute care wards to develop patients' system management plans, discuss advanced planning, end-of-life care, goals of care, and to provide psychological support. She also works in the cancer pain clinic with patients that experience pain before and during or after their cancer treatments. She has been a nurse for over 18 years and loves providing a holistic approach for patients and families. She has done volunteer work with Camp Ooch, Young Adults Cancer Canada, and Dr. J's Children's Grief Centre, and all of these organizations hold a place in her heart. She has recently published a book containing reflections on being a palliative care nurse titled Love and Loss, a collaboration with an artist, Ramune Lumiere. She is passionate about the idea of staying connected to creativity and how this can increase resilience, empathy, and compassion. Over to you, Jocelyn.
Hello. I'm really excited to be here today to discuss with you the role of the nurse in providing the palliative approach to care for malignant heme patients. Thank you to the Leukemia Lymphoma Society for inviting me to present on this topic. I've been working with the malignant heme population for almost 20 years. Prior to my current role, which involves working on the malignant heme inpatient units, providing palliative care consultations, I worked on all of the different malignant heme units for about 5 years as an RN, supporting newly diagnosed leukemia patients, patients receiving allo transplants and auto transplants, patients with multiple myeloma and lymphoma at various points in their illness trajectory. One of the motivators that pushed me towards becoming a palliative care clinical nurse specialist was recognition of the importance and value of integrating the palliative approach to care for these patients and teams. I love poetry, and I wanted to share a beautiful poem by Mary Oliver with you all so that we can both ground ourselves and feel embodied and receptive and ready for this session today. When I am among the trees. When I am among the trees, especially the willows and the honey locust, equally the beech, the oaks, and the pines, they give off such hints of gladness. I would almost say that they save me, and daily. I am so distant from the hope of myself, in which I have goodness and discernment, and never hurry through the world, but walk slowly and bow often. Around me, the trees stir in their leaves and call out, "Stay a while." The light flows from their branches, and they call again. "It's simple," they say, "and you too have come into the world to do this, to go easy, to be filled with light, and to shine." By Mary Oliver. For me, when I read this poem before stepping into the place of talking about the palliative approach to care with you all, it almost feels like a poetic example of the nurse stepping into the place of providing a palliative approach to care for patients and families. The meaningfulness, the noticing, the taking a pause to walk slowly and bow often. And then the way the poem ends, to go easy, to be filled with light, and to shine. I think that is what we are trying to accomplish with integrating the palliative approach to care, making things easier for our patients and families, helping them feel filled with light through providing skilled support and symptom management, and ultimately, hopefully, helping them to shine. The goal of this webinar is for you to learn more about the palliative approach to care and to increase your knowledge, skills, and capacity to integrate this approach into your practice. I will also review the complexities of involving specialized palliative care services for malignant hematology patients. I really hope that you feel more prepared to advocate for and meet your patients' and families' needs after this session. As you know, there is such a range of patient and family experiences within the various malignant hematology diagnoses. From the sudden onset and trauma that patients experience when they are diagnosed with acute leukemia and are suddenly facing a life-threatening illness with a heavy burden of symptoms and an intense treatment routine, to the ongoing chronic impacts of multiple myeloma causing frailty and pain for prolonged periods of time with treatments that can last decades. This is a broad scope to cover, but I'm hoping that the information in this webinar will speak to your experiences and help you feel like you are more capable of providing a palliative approach to care for your patients and families, enhancing your skills and knowledge. Palliative care is a holistic approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through early identification and impeccable assessment and treatment of physical, psychological, social, spiritual, and practical needs. It is important to note that quality of life is defined by the individual. Addressing suffering involves taking care of issues beyond physical symptoms. Palliative care uses a team approach to support patients and their caregivers, addressing needs from a holistic perspective. It offers a support system to help patients live as actively as possible. Palliative care is an extra layer of support that is appropriate for all patients suffering from serious illness at any age and at any stage, and can accompany curative treatment. This is the summary of palliative care values from the World Health Organization. I'm not going to read through them all, but I wanted you to have these for your reference, as this is a summary of many of the concepts we will touch on today. Imagine taking care of a patient, knowing what their goals and values are, and knowing that these were guiding the plan of care. And you felt like they really understood what was happening to them now and what to expect in the future regarding their illness, trajectory, and care options. Imagine knowing that they were making fully informed decisions based on their goals and that you were able to provide excellent symptom management for them and support their family. This is what we were trying to achieve in the palliative approach to care, helping patients feel a sense of autonomy, control, dignity, and integrity, and achieving this through ongoing conversations about goals of care and advanced care planning and excellent symptom management. This is a diagram of the model of when palliative care should be included into a patient's illness trajectory. As you can see, the palliative approach to care can be provided upon diagnosis, and the role of palliative care may increase over time, involving specialized palliative care services when symptoms become more complex or there are other complex psychosocial needs to be addressed. As patients move towards end of life, they may need more aggressive symptom management and support. You can see that palliative is an approach to care that can be provided at any point for patients. But when are we actually involving specialist palliative care services for our malignant hematology patients? How will you or your team start talking to your patients about involving specialist palliative care? These are some of the questions I will address in this presentation. This diagram shows how palliative care delivery can change through a person's illness as their needs become more complex. Patient A is a patient with complex palliative care needs that may require a referral or transfer to a specialist palliative care team. Patient B is an example of a patient that may require consultation to a specialist palliative care team and will then have clinician-to-clinician support between their primary team and the palliative care team to meet their palliative care needs. This is called shared care. Patient C is an example of a patient whose palliative care needs can be met through primary level palliative care, known as a palliative approach to care. This care may be delivered by many different types of healthcare providers, including primary care clinicians such as family physicians, nurse practitioners, family health teams, community nurses, home health care providers, pain and symptom management consultation teams, and emergency care, as well as non-palliative specialist clinicians such as oncologists, internists, geriatricians, and multiple other different specialties. Palliative care can be provided in any setting and is provided by a multidisciplinary team. As you are aware, the integration of the palliative approach to care into the care of patients with hematological malignancies is complicated for many reasons, and we will touch on a few of these today. Patients with hematological malignancies receive less palliative care initiated at a later disease stage compared with patients with other types of cancer. Most patients with hematological malignancies have a high number of symptoms, many of which are severe. Compared with patients with solid tumors, patients with hematological malignancies have a similar burden of symptoms, such as pain and depression, but are more likely to experience fatigue, adversely affecting their quality of life. I'll talk a little bit about some of the barriers to providing the palliative approach to care in the malignant heme population. Barriers to the involvement of palliative care for patients with hematological malignancies occur at the patient level, healthcare provider level, and institutional level. Patients and families often need education about the role of palliative care, specifically clarifying that palliative care is not just end-of-life care. McGawkin and colleagues analyzed the barriers reported by doctors and nurses from specialist palliative care services, the most common of which were the characteristics and pathways of hematological malignancies, for example, the uncertainty of prognosis and intensity of treatment in advanced disease, the close relationship between patients and the hematology team, the absence of clarity regarding the role of palliative care, late end-of-life discussions and referrals, policy issues, and organizational issues. For example, palliative care unit and hospital admission criteria regarding transfusions and antibiotics. The palliative approach to care includes advanced care planning, which helps patients and families plan for the care that they want at different stages in their illness based on their own goals and values and on a clear understanding of their prognosis and treatment options. An important part of the discussion is really sitting down and talking to patients and families about their full understanding of the illness and what they are expecting in the future. Part of the nurse's role is to gather this information and let the team know about the patient's understanding. If the patient and family do not have a full understanding, then a family meeting or further discussions with their primary team might be required so that the patient can make informed decisions about their care. Some examples of questions to ask patients include, is the illness curable? Has your team talked to you about more treatment options, and do these treatment options align with your goals? What are your goals? Has your team had discussions with you about prognosis? If not, are these discussions that you would like to have? If so, what did they tell you? Let's review some of the benefits of palliative care. Evidence suggests that when palliative care needs are identified and services are provided earlier, the patient and their family tend to experience better quality of life, mood, and greater satisfaction in care. There tends to be greater participation in advanced care planning, fewer hospitalizations, and lower medical costs. For some, there is also an indication of longer survival time as compared to those who receive palliative care later on in their illness trajectory. Avoidance of early palliative care can result in less symptom control, less emotional support for patients and their relatives, and more intensive treatment before death. The vast majority of Canadians believe that hospice palliative care has a positive impact. The following are statements about hospice palliative care that see a large majority of Canadians either agreeing or strongly agreeing. They feel that it greatly reduces the stress and burden on the family, should involve all care providers, improves quality of life for patients, should be provided in the setting of choice, should be integrated for all people with chronic and life-limiting conditions. It helps patients manage their choices along the way, and it should be available early in the course of the disease. We talk a lot about goals of care in palliative care, as keeping goals of care at the forefront helps guide treatment decisions in a patient-centered way. A person's goals of care are their overall priorities and health expectations for care. These are based on their personal values, wishes, beliefs, and perception of quality of life, and what they identify as meaningful and important. Examples of goals of care could be curing the disease, prolonging life, relieving suffering, optimizing quality of life, maintaining control, achieving a good death, and getting support for family and loved ones. Goals of care are not the same as healthcare decisions or consents for treatment. Part of the nurse's role is to discuss goals of care with patients. What are your goals? What is most important to you? How do you want to spend your time? Where do you want to spend your time? You will find your own language that feels comfortable for you to help you to explore the goals of care. I will give you a few more examples of questions in the upcoming slides. Of course, goals of care discussions occur with the interdisciplinary team and are not just solely the nurse's role, but everyone on the team can have these discussions to help guide a patient's decision-making framed by their goals of care. Advanced care planning is an ongoing process that involves encouraging capable adults to have meaningful discussions about personal values, beliefs, and possible future medical decisions with their loved ones and healthcare providers. Does your patient know who their future substitute decision maker is? Part of the nurse's role is to encourage ongoing communication between your patient and their substitute decision maker or power of attorney, so that the substitute decision maker or power of attorney is empowered to participate in the healthcare consent process if required. This website is a very helpful resource, and specifically for patients. If you can review it, and it can provide you with a lot of tips, communication tips, and other information about advanced care planning. There's a booklet called Speak Up Workbook, and it's a book that patients can use to fill out some of their healthcare wishes in. And I wanted to just highlight the difference between substitute decision maker and power of attorney for personal care. Specifically in Ontario, patients automatically have a substitute decision maker assigned to them based on a hierarchy. And then if they don't agree with that hierarchy of an assigned person, they need to fill out a document, which is called the power, and assign that person to be the power of attorney for personal care. This process is different from province to province. Patients may have varying goals of care, and these goals may be changing frequently. The goals of care will shape the care plan and what interventions are provided. The information in this slide reviews some of the different types of approaches to care, from full aggressive medical management provided on acute care wards to comfort measures that can be provided in a hospice or palliative or home setting. For malignant hematology patients, deciding on focusing on comfort measures brings unique challenges, as many patients are dependent on transfusions and IV antimicrobials because of pancytopenia and chronic infections. This dependency can unfortunately inhibit a patient's preferred location of care, as these treatments are only available in the acute care setting. We often support patients with the palliative consult service at my hospital on the acute care wards, as they are receiving what is called best supportive care for prolonged periods of time, in which they receive ongoing frequent transfusions and multiple IV antimicrobials. Sometimes, after being aware of all of their options, patients and families decide that if there are no further anti-cancer treatments, or these anti-cancer treatments will cause unacceptable adverse effects, negatively impacting quality of life, they may choose to be closer to home in a palliative care unit or hospice setting, or at home with maximum supports from home care when their goals of care are focused on comfort measures. Why refer to palliative care? We know from the research that involving specialized palliative care has many benefits. It improves symptom control and quality of life. It also reduces psychological distress and enhances patients' coping strategies. It helps family caregivers, addresses patients' social needs, enhances prognostic understanding, facilitates end-of-life care planning, and helps prepare patients emotionally and psychologically for end of life. As we know from the information we have already reviewed, that palliative care is an approach to care that can be integrated at any time. We often follow patients for mucositis pain or other refractory symptoms on the palliative care consult service on the acute care wards, as the burden of symptoms can be heavy for these patients receiving their intensive chemotherapy. And this is a good time for you to advocate for a referral for patients. Due to human resource limitations in healthcare, not every patient with a hematological malignancy can have specialized palliative care services involved. Hopefully, we are moving towards building capacity for every healthcare provider to be able to integrate the palliative approach to care into their routine practice. For patients with hematological malignancies, there have been studies identifying specific triggers for referral to specialized palliative care. The study by LeBlanc et al. Identified 6 general indicators that are associated with the risk of death in people with hematological malignancy within 3 months. These include declining performance status, presence of at least 2 comorbidities, disease status such as relapse, refractory, or persistent disease, persistent bacterial and viral infections, and invasive fungal infections, and treatment limitations. If your patient can be included in any of the above categories, then you should advocate for specialized palliative care services to become involved. Do you have rounds that you could bring this up in? Patients also need to agree to have palliative care services involved. You can start educating your patients about the definition of palliative care and how it is an extra layer of support, so that when the primary physician brings up the referral, the patient and family are more educated about what it means to have palliative care involved. Things can change quickly for patients with hematological malignancies, as you know, due to complications from infections or pancytopenia, which can be a very intense experience for patients and families, and also you as a nurse caring for the patient. If your patient fits into any of the above points from the previous slide, things might be changing for your patient, and this might be the time that more discussions need to occur about changing focus and goals of care to more supportive measures or comfort measures approach, as they may be coming closer to the end of their life. When a patient's condition is changing, you can consider, have we discussed a referral to specialized palliative care? Has the patient been anticipating these changes and preparing? Have we done advanced care planning or had advanced care planning discussions with the patient? And what are the patient's goals? And what is their prognostic awareness? And is the patient aware of their treatment options? And are they making informed decisions based on this information? And does the plan of care align with the patient's goals of care? When a patient's condition is changing, we can also consider, is the patient aware of all of their options and that they have choices? Some of these options include focusing on best supportive care or on comfort measures, and maybe their goal is to avoid the acute care setting, so palliative planning needs to be explored and discussed. Are they aware of options for where they can have end-of-life care? Has palliative planning already been discussed and decisions made, such as home versus hospice or palliative care unit versus the acute care setting? Many people try to stay at home for as long as possible. Does your patient know what that would look like? The specialized palliative care team and social workers can have these types of discussions with your patients. When the patient's condition is changing, it's an opportunity to explore when and if the patient may want to change their goals of care to focusing on best supportive care or comfort measures. When their condition is changing, it's important that they are aware of all of their options and that they can change their goals. Patients might want to change their goals of care when they have refractory disease, when they have ongoing persistent infections, when they're bedbound or feeling a loss of dignity and independence, when they are no longer able to communicate meaningfully with their loved ones, if they have a change in their cognitive status that's irreversible, or when they can no longer make it to the hospital frequently for transfusions. Do they still feel like they have quality of life? And treatment options may be offered, such as palliative chemo for these patients. Does palliative chemo fit with their goals of care? Are they aware of the adverse effects of palliative chemo and how that will impact their quality of life and potentially their goal of being at home? Let's talk about your role as the nurse. Your role includes knowing what palliative care is and knowing how to advocate for a consult, identifying patients who would benefit from a specialty palliative care consult for complex or intractable symptoms, and educating patients and families about what is involved in the palliative care approach and what specialized services can offer, how it is an extra layer of expertise support. The level of your involvement with the above discussions will depend on many factors, including your therapeutic relationship, how long you've known the patient, or your comfort level with having these discussions, and even your role as an RN or an APN and the dynamics of your team. The next few slides, I'm going to review a few general points about the nurse's role and in integrating the palliative approach to care. When nurses at home or in the hospital are spending so much time with patients, you have an understanding as to when your patient situation is changing and when you may need to advocate for a referral to a specialized palliative care service. It would be ideal if palliative care could be integrated early, but if you're caring for a patient and they do not have a specialized palliative care team involved, and their condition is changing or is challenging, and you think they have needs that can be met by specialized palliative care, or either specific symptoms or support, then hopefully you're able to advocate for a referral. The role of the nurse and interprofessional team caring for the patient receiving the palliative approach to care is to identify a patient's palliative care needs through a holistic, comprehensive assessment, develop an individualized and patient-centered plan of care with the interprofessional team. Ongoing reassessment, evaluation, and adjustment in the plan of care should occur based on the patient's changing symptoms and other psychosocial needs. The nurse's role includes screening for common symptoms and advocating with team for effective management of these symptoms. The ESAS, which I will show you soon, if you're not familiar with it, is the Edmonton Symptom Assessment Scale and allows patients to score their symptoms on a scale of 0 to 10 in intensity. This screening tool can be utilized to guide your holistic assessment. Exploring their needs, concerns, preferences, goals, and values is part of the nurse's role. Also, facilitating communication between the patient and family and healthcare team is important. Ongoing assessment to review if the goals of care align with the plan of care is part of your role. And if it doesn't align, then you might need to advocate for a family meeting. We'll continue talking about the role of the nurse. It includes assessing caregiver needs and helping patients to identify their power of attorney or substitute decision maker, and supporting patients through transitions in care settings, such as from acute care to home or home to palliative care unit. Depending on your role, you may also work closely with a specialized palliative care team to provide end-of-life care for your patients. As we discussed earlier, many malignant heme patients die on acute care wards because of the nature of their illness trajectories. So you may be working alongside the palliative care consult team to provide care for your patients at the end of life. Education that the nurse provides plays an important role in increasing patient and family's knowledge about their care, helping prepare them for decisions they will need to make. The education provided by the nurse can increase a patient's sense of self-control and well-being. Education about symptom management and coping strategies improves symptom control for patients throughout the illness trajectory and at the end of life, and improves quality of life for caregivers. It's important that the education provided is sensitive to linguistic and cultural preferences and health literacy. This slide includes a full examination of the domains of care associated with illness and bereavement. The palliative approach to care is provided by an interprofessional team, including social workers, spiritual care pharmacists, and physicians. This is a comprehensive slide of the domains of issues associated with illness and bereavement. So the print is really small, but you can find this in the Canadian Hospice Palliative Care Association model to guide care. And I'm not going to go over all of the bullet points in detail, but you can see that it's reviewing a holistic assessment, including the physical, psychological, social, practical, and spiritual needs of patients. So I find this slide really helpful, and especially when I was starting my practice in palliative care, of just a reminder of all of the different things to assess and cover when you're providing and integrating the palliative approach to care into your practice. Pain and other symptoms that cause discomfort can be caused by underlying disease or by the cancer treatments and the side effects of these treatments. If pain or other symptoms are identified, they should be managed promptly and effectively, and any reversible causes should be treated using evidence-based practice. Pain and symptom management requires ongoing reassessment to ensure the efficacy of interventions and monitoring for changes in symptoms. I did mention the Cancer Care Ontario Symptom Management Guidelines, and I'll show you an example of that in a moment. This ESAS it's the ESAS AL, which is ESAS for acute leukemia patients, was specifically designed for patients with acute leukemia. And we use this for an early intervention of palliative care study that we're doing at Princess Margaret for newly diagnosed leukemia patients. And you can see that the symptoms included are not all of the include mouth sores, diarrhea, and itching, in addition to the standard symptoms normally included on the ESAS, as these are more common symptoms for the acute leukemia patients. This is an example of one of the guidelines for pain management from Cancer Care Ontario. It's a very great resource. I have a lot of resources in the slides at the end of the presentation. And they have different guidelines for various symptoms, as well as patient education pamphlets. And I often print out the patient education pamphlet on shortness of breath or insomnia or pain for patients so that they can read through it with their family members and find some new strategies to help manage their pain. This is just another example of the continuation of the pain guideline by Cancer Care Ontario. You can see how it's divided into different interventions for mild, moderate, and severe pain. And many of the symptoms that are outlined in the Cancer Care Ontario guidelines are divided into this category, and then these categories, and then you can identify the different interventions based on the intensity of their symptom that they're experiencing. The depths of discussions about causes and interventions may depend on your role, but providing patient and family education is an important part of the nurse's role. You could review possible causes of the symptoms, talk to your patient about the medication and side effects and non-pharmacological interventions, and then also reviewing interventions based on what the goals of care are and reviewing benefits and harms of different interventions. I'm just going to talk about the psychological domain for a few minutes. And the assessment should identify how quality of life is defined and experienced by the patient. The assessment should identify their goals, barriers to achieving those goals, and strengths available to overcome and adapt to the presence of constant change and uncertainty. When people face a progressive, life-limiting illness, psychosocial issues may go undetected or untreated, and this can impact their quality of life. Pain and other symptoms may be the initial focus of treatment, but psychosocial well-being should also be assessed regularly. A holistic psychosocial assessment can facilitate the identification of supports a person might need during their illness. And I brought up these are some examples of some questions that you can ask your patients for your psychosocial assessment. Then I also wanted to mention the concept of total pain. The concept of total pain describes the suffering that expands beyond physical pain by encompassing all of a person's physical, psychological, social, spiritual, and practical struggles. So acknowledging that all of these different parts of a patient's experience can impact their quality of life and their overall experience, and we need to be mindful and do a holistic assessment and figure out what is going on with the patient so we can implement the proper interventions. And obviously this is a psychosocial assessment is completed by the interprofessional team, not just the nurse. This slide provides examples of how to elicit values from patients. And many of the questions and concepts are repeated from previous points I've already made, but I wanted to include this slide as I think it's beneficial to have multiple examples of prompting questions so that you can find your own unique language that you are comfortable with when having these values-based discussions with patients. So the purpose of values-based discussions is to Identify what the goals of care are for our patient so that you can relay this information to the team and help patients articulate this so that they are able to make treatment decisions based on what their goals of care are. I won't read all of these out, but I think having many different prompting examples and finding your own language and how you're comfortable in having these conversations with patients is important and a skill that you can develop over time. Again, many of these questions, these are more example questions for psychosocial assessment. They're repetitive, but with more, I wanted to give you many question examples so that you can conduct a holistic psychosocial assessment, which provides key information to help the patient understand their experience and also develop a plan for ongoing support based on the patient's perspectives and what values they have. So commonly we ask patients about their understanding of their illness. This really helps us gain insight into their perspective and relay this information back to the team so that everyone on the team understands where the patient is at in their understanding. And also, how they're relating to their family. And often we ask patients about what their expectations are, what their hopes are, what their fears are. And all of this information is helpful to gather to help patients identify their goals of care and to understand the values of patients. These are some specific validated tools related to psychosocial assessment. Just wanted to give you a few different examples, but I won't go into any of these in detail. You can just look them up on your own time and use them as a resource. And this is a list of psychosocial interventions that you can include in your practice to help support your patients and meet their psychosocial needs. We spend a lot of time as nurses providing information and which helps reduce uncertainty and really helps patients helping patients gain a sense of autonomy, control, and dignity. Spending time talking to patients about reframing hope and also reframing their goals. Maybe previously they were hoping for a cure, but things are changing for them. So identifying what their goals, helping them reframe their hope and identify what their new goals could be, such as improved symptom management or spending more time with family. And also really exploring what their internal and external resources are. How are they coping? Do they have, and who is involved with their support network? Advocating for patients, normalizing the experience. A lot of time, I'm very lucky that I'm able to sit down with patients and listen to their stories. So spending time and giving them a space to tell their story. I was just speaking with a patient today that was diagnosed 2 years ago with leukemia, and she's gone through transplant and everything and is now has a poor prognosis. But I just spent time with her, giving her the space and allowing her to tell her story. And she's been through so much over the past couple of years, and that's important for patients to be able to tell their story. Advocating for a family meeting might be needed. And also, we obviously have a full interprofessional team with social workers, psychologists, psychiatrists. You might need to make referrals with your interprofessional team. We're lucky here at our hospital, we have music therapists. So you might need to reach out and make referrals depending on what's going on with your patient. And I just wanted to highlight a few other practical, in the moment psychosocial interventions that you can offer for your patients. Helping them, encouraging them to write down their thoughts and creating a personal coping kit. I often encourage patients just to write a list of things that energizes them, such as listening to music or calling a friend. And then if they're feeling a bit down, just reviewing that list and just taking action and doing one of those things that they've already identified, asking for help, and then just the simple act of just taking a pause, taking a moment, and taking a deep breath. Listening and talking to patients is one of the key skills in palliative care. And active listening is a valuable skill because it allows us to demonstrate our understanding of what another person is saying and feeling through empathy. Active listening does not mean the same as agreement, but it's a demonstration that you intend to hear and understand another's point of view. The skills in active listening include restating, paraphrasing, reflecting back to confirm and ensure understanding of what is being expressed, responding to feelings, and summarizing, and also checking perceptions and allowing for silence. There's a lot of different communication strategies and tips and skills that can be learned. I could do an entire separate presentation just on communication, but I wanted to just give you this one tool that can be used for responding to emotions. That is the bathe tool. So looking at the background information and asking them what's been going on, how has it affected them, what's troubling them the most, how are they handling the situation, and also then providing empathy and validating their experience. There are a few more, these are a few more resources, including Vital Talk and the Palliative Care Communication Institute that you can explore more on your own time, so you can increase your communication skills related to integrating a palliative approach to care for your patients. And I really wanted to highlight at the end of this presentation that it's just so important to have self-compassion within your nursing practice and when you're learning how to integrate the palliative care approach for your patients and your families, because it can be really intense time supporting patients through transitions and when they're experiencing a lot of symptoms and psychosocial distress. Just make sure that you're taking time to be kind to yourself and doing some reflective practice and self-awareness, and making sure that you're really taking care of yourself. Everyone has different things that they enjoy doing or that bring them energy. I like to read poetry, I like to write, listen to music, and it's just important to be kind to yourself. And especially, a lot of these things that I've talked about today, there's from novice to expert skill level, and just learning that, communication skills can be improved, and even your symptom management skills, communication skills, how you're talking to patients about advanced care planning. It's all a process of moving from novice to expert, and just be kind to yourself when you're first learning these skills, and things will improve over time. So just to end off the presentation, just a summary of what palliative care can provide. Really just want you to take away that can provide improved quality of life for patients, and opening up those lines of communication, having those advanced care planning and goals of care discussions, really helping improve symptom management, and decreasing the burden of symptoms for patients, and the trauma of the experience for patients and families as they feel more in control and more autonomous, and feel more involved with their care and more aware of what's going on. And it just provides that extra layer of support. And it also facilitates hope and gives people the opportunity to have discussions with the healthcare providers and with family members as well, around what's going on with them and their illness experience. I just wanted to end with a poem as well, as I began with a poem. Another world is not only possible, she is on her way. On a quiet day, if you listen carefully, you can hear her breathing. When I read this, I just felt like it felt very hopeful, and it reminded me of the fact that we're really trying to integrate the palliative approach to care into all of our patients' experiences, and that I think things are changing, and we have become very much more integrated with the malignant team and population at our hospital, being involved with the allogenic stem cell transplant rounds and different ways that we're more involved, getting more consults. So I think things are changing, and I hope you gain some information from this presentation so that you can integrate the palliative approach to care more into your practice. There are some resources here. There's a lot of resources. Canadian Virtual Hospice has many amazing videos, webinars, different things that can improve your knowledge around communication, symptom management, grief and bereavement, and many different topics. Canadian Nurses Association, I won't read these all out, but I do highlight the one that I mentioned, Cancer Care Ontario, their symptom management guides. The D'Souza Institute has a course on palliative care, which you can take to increase your knowledge as well. And I mentioned previously in the presentation, the Speak Up workbook. There's also a book called Voicing My Choices, which is for young adults to complete on advanced care planning. And then there's these, I find these documents very helpful when you're wanting to learn about how we are integrating the palliative approach to care. The Way Forward document was developed almost 10 years ago now. It outlines a roadmap for integrating the palliative approach to care. And this is a more recent document, the Ontario Palliative Care Network Delivery Framework, which outlines specifically how we're starting to integrate the palliative care approach throughout all the illness experiences. And then the quality standard document outlines many different points of how to provide a quality palliative approach to care. There are some references that I've used. And I just wanted to say thank you so much. Thank you so much to the Leukemia Lymphoma Society for inviting me to do this. I hope you all learned something from this presentation, and it was a pleasure spending this time with you today. Thank you.
Thank you so much, Jocelyn, for this very interesting presentation. I want to reiterate that you can use our continuing education program at your convenience. You see on the screen all of the selections available. And finally, I would like to remind you that we are here for the blood cancer community. We can help those affected by a blood cancer to cope with every step along their experience. You can order material to refer your patients and their families to our services easily. Thank you and stay safe.